So we were looking at the tibia here, and then we had to get into this contour. That's where you need plenty of jelly there. And then you want to get to the sort of talus a little bit, and then come back again. And then of course you're going into your transverse section, scanning down, looking into the mortise and past it. Always go a little bit higher and lower than the area that you're looking at. When we got to the medial ankle, inner side of your foot, we were looking at this plane to find the medial ankle structures. And then laterally, if I spin the foot around, we were looking at the peroneal tendons and the CFL in this structure. So your ATFL, AITFL, ATFL, and then CFL. You almost, you can kind of find them all by clock facing. So with your probe, you just try and get the angle here. Do that, and you should be able to pick up all three ligaments. So we'll cover that in another program. By the time we finish, you should be quite proficient at finding those three important ligaments in one sweeping movement. Give or take a little bit of a, as everybody's anatomy is slightly different. Okay, so let's get plenty of jelly on our probe first of all. Adrian's camera is on my probe. What we're going to do here, we want to look at the anterior ankle. So of course, remember in your anatomy, you've got your extensor, you've got your tibialis anterior over here, extensor hallucis, and then you've got your extensor complex here of the digitorum. And then you've got your deep ankle mortise, which we'll be looking at. And possibly we might even need to touch on the talar navicular joint a little bit, because I personally think if you're going to examine the ankle, you should look as far as the talar navicular joint. Okay, so with our gelled probe, we're going to start off somewhere on the lower third of the shin. So palpate your bony landmarks, find the medial ankle bone, and you know you're pretty much on the tibia. You want to start with a local bony area that you can easily see. So straight away you can see we've got a very thin layer of skin at the top here and a little bit of tissue, and then we're straight onto the bone. So the tibia bone is the bright white line, which Adrian is marking out there with his yellow cursor. So you can see anything after the white line, it pretty much goes dark. We have lost signal here. The ultrasound probe signal is unable to penetrate past the bone. So we can see the tissue very well. We can see the cortex of the bone very well. You could even pick up stress fractures here very nicely, but of course you can't see any further detail of the bone, certainly not through the bone. So starting here, we're going to make sure we know where our probe orientation is there. So you want to make sure your marker's in the right place. So what I like to do is just rock the boat a little bit, and I can see that the right-hand side of the screen is the right-hand side of my probe. If I just demonstrate the other way, if my probe was the wrong way around, then I'd be lifting this end and I'm looking at the opposite end. Yeah, so we want to have it in the right plane of motion, back on the bone, making it nice and bright white. Okay, so
got the focus up here, nice and superficial.
And we've got the frequency set on the highest setting.
17.
17. Thank you. And we're using a 9L probe?
Yeah, so 12L.
12L probe, sorry. Okay, so let's follow the tibia then. We're going to follow it up for you just to show you a little bit more bone. And now we're going to start to follow it down the tibia. I like to just wiggle forwards and backwards as I'm moving, because we're kind of interrogating the bone a little and trying to stay, keeping it bright white. Okay, I'm just going to get a bit more jelly because it's going to get sticky there.
When you have the bone bright white, that's when you're perpendicular to the bone. So if you go off slightly to the side, you'll see that the bone goes fuzzy, and that means obviously you're not directly over where you want to be. So you want a nice bright bone, and then you know you're 90 degrees to the bone.
See how it's going sluffy there. I've lost the contact. I've only tilted my probe very slightly, but we've lost that nice bright white line. So small fine-tuning movements here are required. Okay, let's carry on moving downwards. So we're, of course, I like to start this as well in the long axis, just because I like to pick up the ankle mortise first of all. So you can see now there's a drop. There's a little step appearing, a little drop appearing now. And I'm going to keep following that. We've come to the end of the tibia. A bit more jelly. Come to the end of the tibia. And what we're looking for is a sort of a V shape. Can we have a little bit more superficial, please? So we're just going to go out a little bit more. Now we can see the talus appearing.
It should be.
Just see the bone here on the left of your screen.
If I pause that.
Apologies, rest your knee on my foot on my knee there.
That's the talus.
You've got quite a big ankle. Can we come out a little bit? Make it more superficial.
Oops,
Too deep there.
Not too much, was that? I'm going to bring my focus down a bit.
So you can see we're having to make some quite a few adjustments here to really get this image nice and clear for you. That's better. So do you want to? Let's put the tendon in the view. Okay. So here's a nice image for you. Would you like to annotate that for me?
So we've got. We're on Tibant then.
Yeah.
So this is Tibant at the top here.
So there's your tendon.
So this will be the tibia.
You're just seeing the end of the tibia there. Then you're seeing a space in the middle, which we'll point out in a second. And that's the talus starting to come into view. So don't forget, we're looking down through the layers. So you're looking at the ankle mortise in between the two bones. So this area here is tissue, but no bone. Your talus is a bit deep, isn't it?
Yeah.
He's got a deep talus, guys. Okay, so let's go down a bit further and let's show you the navicular joint. So can you see here, we're just on the body, the top of the talus. Keep that signal nice and bright. And then here we've just approached the navicular joint, which I'll just rotate a little bit so you can see some movement in it. So we're looking down at the superficial part of the joint. We can't see any deeper than that. We can just see the periphery, but you can make out degenerative changes here. If you want to freeze that image for me there, please. So you can see in the navicular joint here, it looks quite clean lines inside the joint. There's no osteophytes, there's no calcific deposits. There's no effusion sitting in there. It looks quite nice and round and healthy. The two ends of bone are coming together.
I've frozen that in there.
Back on it. And you can just see a bit of ligament over the top of it as well. You make that little white hyperecho line is the dorsal talo-navicular ligament. Okay, right, let's go back. I'm just going to take the probe off, get some jelly around the area so it's drying out. Let's get a little bit more on there. Okay, so plenty of jelly because, of course, it contours here. And so you can end up losing contact with your probe because, of course, your probe is a straight line. It's not curved, but the ankle is. So plenty of coupling jelly in there so you can make your way around that angle and keep a good image in the picture. So let's come back up to the tibia here. And as you can see, we can see the extensor. What's this? Extensor, let's stay on the Tibialis Anterior for a second. And if I carefully hold my probe in this position, I can ask Adrian to move his ankle up and down, dorsiflexion, plantarflexion, and you can actually see the movement in the tendon. You can also see the separation between the tendon and the paratenon. And you can see the nice stripy fibres. Do you want to make out the paratenon for these guys, please, Adrian?
So this sort of dark halo around the tendon.
So, of course, if we are injecting tendons, it's that sheath, that layer that you want to get into. You don't want to go into the body of the tendon. You want to go into this layer sheath. So doing ultrasound-guided paratenon injections is really nice and simple with ultrasound. Okay, so what we're going to do now is we're going to move our probe here from the longitudinal plane to the transverse plane. We're going to start on the medial side. Again, making sure your probe's in the right place. Let's find, let's show you a broad picture first of all. Okay, so I'm right on the front of the ankle, anterior part of it. So this is what you're going to see initially. So I'm actually on the tibia here. You can see the tibia underneath, so I've not gone over the ankle mortise yet. And we're just going to freeze there and point out this anatomy to you. Oops. So on the right of the screen, your right, yeah, no, sorry, left of the screen. That's your tibialis anterior. So it's a nice big chunky tendon. Yeah, nice shape, slightly oval at this point, and then it becomes slightly more cylindrical a little bit further down, and then it goes oval again as we're going down the dorsum of the foot. Then we have the Extensor Hallucis longus tendon just in view there. Adrian's marking out with his yellow marker.
I lost it a bit here, so let's just...
Lost a little bit of image there, so let's just get a better picture. Yeah, of course, again, because we're losing some image on the lateral side, because of course our probe again is straight and the ankle is curved, so we've got a fall off the end here. So we're going to have to do this ankle exam in two components. We'll kind of start medially, go anteriorly, and then to make out the more anterolateral structures, we're going to have to move our probe position. So it's going to be very difficult to see the whole of the ankle with just one footprint of the probe. It's not broad enough here, and also the ankle is just too curved. So you're going to need to work around it, trying to keep the structure that you're interrogating in the picture. So again, we start at the lower end of the tibia before we get to the ankle. So let's go back to our image there.
So that's tibia anterior zoom.
Let's give your ankle a bit of movement up and down. See tibia moving there. Then we've got, if you wiggle your big toe, Adrian, you can see the actual muscle belly as well of Extensor Hallucis. We'll go down a wee bit further. You can see the tendon as it starts to form into a tendon. And so you can help yourself to find your anatomical positioning by asking the patient to move the ankle, the big toe, or even the little toes. Let's go down a bit further, and you can see how that. Can you see how the muscle belly there is starting to disappear as I move distally down the foot, and now it's just become this thin, more ovoid shape, which is the tendon itself.
Abid, do you ever use the standoff gels for the sore parts when you're doing down there?
Yeah.
Yeah. Oh, we have that. What's that block thing called?
Oh, you mean it's like a physical standoff? Or, I mean, we don't have them in the hospital, but you can buy standoffs that connect, or you can just use to scan, or you can just use a load of gel as a standoff, or you could, as someone said last week, you can put it in the water if your manufacturer allows that.
Yeah, that did come up the other week, didn't it? Yeah.
Over here in the middle of the screen, you can see your extensor tendon of the flexors.
Extensors.
And underneath that, you can see these two small dark ovoid shapes. If Adrian flicks on the colour flow, you'll be able to see that is an artery there and a vein, and the nerve is to the left of the screen, which will be your dorsalis pedis artery and your superficial peroneal nerve.
Just trying to work out where the nerve is.
Again, the point here is, especially when you're a beginner, you just want to put a lot of pressure on the probe, and we're all maybe a little heavy-handed to start with. But again, hold it like same as a pencil, because if I show you what happens when I put a little bit too much pressure on it, can you see how those three little round, that neurovascular bundle there, I'm compressing it. Yeah, you can just see the artery pulsing away, but I've compressed the artery in the vein. So you can end up mimicking pathology or not seeing things if you compress it too much. You can see we're even compressing the tendons there.
It's a nice mortise view here, look.
Yeah, that's the next layer Adrian's just pointed out there now, with the yellow marker there. That's actually the head of your talus. Yeah, and this black line overlying it is the hyaline cartilage. So again, when you're interrogating a joint, you want to look at it in long axis and transverse. This is the transverse view, so you can see I'm just going to scan proximally up the tibia, and coming back down again till I'm on the mortise. So you can see this nice. So this is what you're looking for: a nice straight line, nice bright white, and a nice amount of hyaline cartilage. If you were to see degenerate features in there, obviously that won't be such a nice bright white line. It'll be a bit knobbly and bubbly, a bit wiggly, and there'll probably be slightly less definition of the articular cartilage. So you can see all the layers here. And then I'm going to move slightly more laterally, and you can just now see the lateral end of the head of the talus.
You can pick up little osteophytes here quite nicely.
Quite common, isn't it?
Yeah.
You'll also sometimes see some kind of floating little calcific deposits around. You know, there's little sort of bits that come off through natural degeneration, wear and tear, or sometimes injury. Actually, if we get a chance, we'll have a little look at Adrian's lateral ankle, because he actually did have an avulsion fracture, and it'll probably be quite good to show you a bit of real pathology there. So just to highlight, do you want to just freeze the image, and then we'll just annotate this picture so everyone's getting their eye around it.
Right, so just going to reverse it in my head. So that's tibant over here.
I think that's Extensor Hallucis.
Oh, is it? Hold on a minute.
And then you've got your Extensor
Extensor
complex.
You're a bit further over, aren't you?
Yeah, a bit more anterolateral. So Extensor Hallucis longus. Obviously, you might remember that mnemonic. How does it go again, Adrian?
Oh, Tom hates Dick.
Tom hates Dick. Does everyone remember that one? Or on the medial side, it's Tom, Dick, and very naughty Harry for your tendons and nerves. Worthwhile remembering and revising, because it's extremely helpful to know your anatomy inside out when you're scanning.
So this is all extensor digitorum here.
So obviously, if we follow that complex down, obviously it'll split off into the 4 branches that go into the toes, which we might just try and show you now. So if we stay on there. Okay, so you can see the artery pulsing away there. And now we're just going to come down. See if we can see the splitting off.
Split the focus a little bit, maybe.
Shows a bit there, isn't it?
A bit more depth.
So you see, as the layers change, we've gone from a fairly deep layer, we're getting more and more superficial, so you need to adjust.
So there'll be like little pancakes. 1, 2, 3.
There you go. You can see the arteries are thinned out as well.
Yeah.
And you can just about make out the thin slips. Can you just point those out for people?
Thin slips.
Just there.
Oh, here, yeah.
So that's the extensor digitorum breaking up. Okay, so let's come back up the ankle. And we're back onto that extensor complex. You can see the artery pulsing away there. We'll put some colour flow there, you'll be able to make out the blood flow. And don't forget, we're still in our transverse section.
All this is artifactual. So if you move, you will create a lot of artifact. So all this is artifactual. This is real, obviously, here. But any movement will pick up all that artifact. So all this wash down here that's coming in.
Not much of anything. Okay, so we've scanned from medial to lateral in transverse. Now we're going to scan from medial to lateral in longitudinal. So again, make sure you start on the medial aspect. Here's the tibia.
So I'm just adjusting the camera here.
I'm just adjusting my probe as well. Get it in position. Apply a bit more jelly. Okay, so we're back on the tibia. We'll ask Adrian to dorsiflex his ankle. And you can just start to make out here the Tibialis Anterior. You should be able to palpate it. And that makes it much easier to get your probe onto it. So there you go, there's your Tibialis Anterior. It's very interesting to be able to view it dynamically. So let's follow this and see if we can go to the insertion. So what you're going to try and do is keep the two ends of the probe on the tendon. So we're just going to follow it down and you'll start to see it thinning out. Just flex your foot a wee bit forward. And then obviously you need to know where it's going to go and insert to make it a bit easier. And now you can see we're heading down underneath the navicular. You see the fibres here, and there it's just going towards its attachment. Adrian's just marking out there. So there's a real nice picture there.
Yeah, so there's a tendon coming down to insert on the first MTP.
Can you see how I'm just very, very slightly clock facing the probe a couple of degrees, just to help me to see the fibres, because with a bit of movement you can pick up the fibres a little easier. And you can see how the tendon's thin right out here to just a couple of millimetres only before it's got to the bone. Okay, so we're on the navicular. Okay, so what we probably should do here now is interrogate this tendon in the cross section as well. So let's find a nice position where we were before. Now you can see the whole tendon in view again. And now we're just going to spin on this, keeping that in the center of the screen. You're going to watch this contracting, 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 and then shrinking into this nice, more of an oval shape. And this is looking now at the tendon in cross section. I think in general, any tendon you interrogate, you should look at it in the long axis and the short axis. And the long axis, you'll see longitudinal and transverse tears, and the short axis is where you'll find the intrasubstance tears.
Yeah.
The easy way for you guys is just ask your patient to dorsiflex the ankle. As long as there's not too much edema around there, that'll make it a lot easier for you to find it. Usually they're quite prominent. Adrian's is not, but I can feel it.
Yeah.
Yeah, it's a simple way. Ask them to lift up the ankle, and you can just find the two ankle bones, the malleoli, and plonk your probe somewhere on the medial aspect between the two. And you're pretty much onto the tendon there. So you just bring it into the center of the screen, and you need to move medial or lateral. Always keep the structure you're looking at in the center of the image. Of the screen, sorry. So you can see it's quite oval. We're looking at the internal fibre. Often if you have a tear, it'll be kind of a C shape, isn't it? Adrian? Yeah. You can get more linear ones as well, but often there's a sort of C shape to it for some reason. They all kind of appear the same.
Yeah, a little defect in the actual tendon, but also you can look for obviously tendinosis and synovitis. You just have fluid around the tendon.
And that would appear as like a black halo.
Yeah.
Which is a kind of a little bit of what you can see there, but of course a little bit of a halo is normal. You should always have a tiny trace amount of fluid in your paratenon, and anything more dark or black than that could indicate something pathological.
And I always tend to use power Doppler, which is that one, because it's a little bit more sensitive than this one. But you can use both, but if you're not picking anything up when you've optimized it with the frequency, then just pop it onto power Doppler and see if that makes a difference. It usually does. So that's the orange one. That's independent of direction, so that's picking up movements in any direction.
So if I move the probe, can you see all the interference there? So you've got to be absolutely still with your probe on the structure. What you're seeing there is a little bit of the dorsalis pedis. Can we focus as well on this tendon a bit, Adrian? Should we show people how we can get really detail into that?
Just
make it nice and big. So you don't have to just look at it more closely. You just increase your depth. It's much bigger and much easier to look at the internal fibres. You see it gets a little bit dark there, but you can see like little white speckles and all the fibres. And can you see how I'm just moving proximally to distally and just trying to keep that in view? So keep your eye on the tendon in the middle as I move it around. And if you start to see it veering off medially or laterally, you just try to bring it back to the centre of your image by adjusting the probe. So you can see there it's moving off. So I'm just going to move along with it because, of course, it doesn't follow a nice straight line. All right, so we can follow this right to the insertion as well, and you'll start to see it and its attachment and it thinning out and fanning out into the bones. We're about here.
I'll take one off the screen now, sorry.
There you go.
There.
Yeah, trying to keep it in the centre. So when we're looking at this, obviously we're not too worried about what's going on around it. All we want to know is what's going on with this tendon. Yeah, now you can just see the tibia at the bottom of the picture again.
Yeah.
And you can see it falling away as we approach the ankle mortis. Now we're passing over the ankle mortis. Now we're just starting to see the talus in view underneath here. Now we've gone over the head of the talus, and now we're coming down to the tarsometatarsal joints. And then now we're pretty much on the navicular. All right. Any questions anywhere there, Steve, about that bit?
No questions directly about that. No.
Okay. Everyone's got a good eye then. They can see what we're doing. That's great. Back up the tibia. Okay. Right. Let's have a little look at the next structure. So we've got our Tibialis Anterior. Just dorsiflex ankle again for me. Let's have a look at Extensor Hallucis. We did cover this in the big toe, so I won't spend too much time here. Let's just get that in the view. Well, let's follow this. So can you see the joint margin just underneath here? That is the tarsometatarsal joint. We're just going to run straight over that and keeping the tendon in view. You can still see the striking curves there. And you can see how much adjusting I'm having to do, as these tendons don't go in a nice, neat direction. You do have to keep adjusting and manipulating to stay on it. And now you can see, if you get stuck, lost contact there, a second. Just wiggle your toe again for me. So can you see how, if you let your toe relax, Adrian, can you see how it kind of melds in to the structures around it? It's not so easy to see. But if you ask Adrian to dorsiflex the toe again, you can see it's a bit clearer and you can see the movement. Although it's a little bit tricky here to keep the probe on it at the same time. That's a nice way of trying to pick it up. If you're really just lost in the deep blue sea there, just move things. The good thing about the foot and ankle is it's not a particularly deep structure. It's quite straightforward to get to see the structures. But of course, it's the contours that you have a bit of a problem with. But the secret there is plenty of gel. So now we've passed over, can we just see the ankle mortis there underneath? Back there, aren't we? Yeah, and now we're just passing up over. Now we're on to the lower tibia, and you can see we've still got the extensor hallucis in view. And now we're starting to lose it in the muscle layer, but we're still there. And can you see how far up the tibia we've come now?
Yeah, you can see the
Yeah,
muscle.
right on the lower third of it. You can see the muscle belly underneath. And we're still following this tendon. Yeah, you can see the fuzzy shade of tibia underneath. But interestingly, we're on the sort of uppermost of the lower third of the shin. I don't think we need to go past that, but you can, if you want to just move your toe again for me, Adrian, let people see the movement of the muscles underneath. And of course, the brilliant thing about ultrasound is you can look at things dynamically. So if I was looking for a tear in this tendon, linear or transverse, I would apply some plantar flexion. Can you see I'm stretching the tendon here? So you want to interrogate the internal fibers by putting some tension onto it. Gapping is often going to make tears and injuries, like that line up, more apparent. And you can see the layers moving. So of course, we're not going to just look at this tendon, and this applies to every tendon. We're not just going to look at this tendon in long section. We're now going to go into transverse section. So keeping the tendon in the middle, I'm simply going to spin my probe. We'll keep the tendon in the middle. And now we're going to follow our tracks back down. The trick being to keep the tendon in the middle of the screen. And we're looking at the internal fibers. We're looking at the halo. That should be about what 1 to 2 millimeters maybe in thickness. Anything more than that is probably a problem. Also at this stage would be interrogating it with the colour as well, to see if there's any inflammatory changes or synovitic changes or paratendinitis. And also we're keeping an eye on the internal structure of the tendon to make sure it doesn't look too thick or too expanded or too many dark patches. We don't want to see, we want to see bright echoes from the fibers. We don't want to see any dark patches that could indicate an internal rupture or a tendinosis, degeneration. So as you can see, I'm just constantly manipulating probe medial to lateral, keeping the extensor hallucis in the middle. I'm just going to follow that all the way down again. I'm just going to speed it up because I've covered it a little bit before. And we'll see it. And there you can see we're starting to lose it a bit, so we'll just ask Adrian to wiggle his toe. And we can make it out again. There we go. It's flattening and broadening out. We'll just go to the MTP joint, keep it in the middle here. And that's your extensor hallucis. Okay, so I think we've covered all the anterior ankle tendons there. Let's look a little bit more at the joint, because that's the interesting stuff. So, let's get a good... You're just not a textbook nice view. Sorry, Adrian, but it has to be said. Can we get a bit more shallow then? Let's try and clear up this image a little bit.
So you want...
I want to show them the nice V, and I want to show them where an effusion would appear.
Okay, let me just...
And just while you're doing that, I'm just going to get a little bit more jelly for the probe. Okay, so back to our linear linear view. Aha, that's better. Yeah, nice. Okay, so that's kind of the picture you're looking for. So you've got the end of the tibia, which Adrian's just marking out, and the top of the head of the talus, and we've got this nice V shape in the middle. So, and you can see the extensor tendon along the top. So that's a nice textbook image. Should we freeze there?
If you are struggling to get down deeper, don't forget you can always alter your frequency. Go down your frequency, and it'll just give you. You see how that's lightening up down here? Just gives you a bit more penetrative power. But we're getting down fine, so I'll take that back up. Sorry, Abby, you want to freeze that?
Yeah, freeze that there, I think. And it's not the best bony image, but we've probably needs adjusting. So if we've got, Adrian's going to show you, if we were to see an effusion, we'd see a big black cloud, just where Adrian's marking with the cursor. And actually, if you were to dorsiflex and plantarflex the ankle, should we just do that for them? Let's get back onto the... Okay, let's dorsiflex, Adrian. I'm going to keep my probe on it. So you can see the soft tissue in the ankle mortise, where if there was an effusion there, you'd see a big black lump of cloud type of shape moving up and down. It really does kind of bobble out. Yeah. And of course, if we're going to do an aspiration, then we can localize it exactly. You can see here, I'm going to use my finger on the side closest that I can get to the probe and just apply some pressure. So you can see there, I'm pressing down, but I'm actually just pressing down on top of the talus. So I'm just going to move my finger up a slight, and now you can see exactly my fingers going into the ankle mortise.
And just remember, you can use this to, differentiate if you've got like a ganglion cyst or an effusion. Usually you'll tend to squish and push around. Whereas a ganglion cyst, you won't.
They stay pretty solid. You just can't change the image. I mean, even the tendon at the top of the screen here, if I just get that back in view. So you can even see me gapping the ankle joint, which we'll do here. So we'll just get a nice view again. Okay, so let's gap the joint and the tendon. See it opening up here. If it's an arthritic joint, we tend to see narrowing of the joint space, so you won't see this nice V shape. Do you want to just point out the cartilage on the, so you can see the black halo overlying the bone. I'm just trying to clear that up for you.
Oh, you bring the focus down.
Oh, perfect. So that's the cartilage at the top of the talus. You can't see all the way down into the talus, but you can see the periphery of it. And then you've got your ankle mortise. So the ankle tends to get narrower. So let's just measure that for them, shall we, Adrian? Okay. So a typical ankle mortise in a just under 40 healthy male should measure.
There.
About 10 mil we've got there.
I'm probably a bit too high for that, but...
Yeah, and bear in mind your ankle is plantar flexed a little bit as well, so that's looking a bit bigger. We just shallow up the groove. I think on average it's about 7 mil, I think, is normal. But of course, if I've got your ankle mortise too close together, I'm losing the contour of the talus. So you have to plantar flex a little bit to really get a good view of the talus. Oops. Yeah, no, carry on. Yeah.
So here.
Do you measure in neutral position, Abid?
Yeah, preferably, but it just depends on the anatomical variance. Bear in mind, everyone's bits and bobs going different directions. I was interested in watching ankle ligament cadaveric studies. And, we always try to look for ligaments in the same plane with most people, but they are very, very different. They are very different. A lot of individual variations. Yeah. Also, synovitis in the ankle joint. We saw a case. You saw a case just yesterday, I think, Adrian, of quite an angry ankle. Lots of synovitic changes. So, shall we try and mimic what synovitis would look like in people? I'll just try and move the probe around a little bit. And you can look at this with colour flow or, so you'd see movement, lots of flashing lights in here. We don't want flashing lights. So if we look at a normal ankle, it should be absolutely clear. You shouldn't be able to make out any coloration at all. If you put this square box on and you see this sort of stuff, that's a problem. Yeah, I think the person we were scanning actually had an AVN in the talus, but associated with that, there was a heck of a lot of synovitic activity going on. They come part and parcel. Sometimes you get an effusion with synovitis, sometimes you get an effusion in isolation. They're pretty common. I see quite a few. I do aspirate quite a lot. You can get a big effusion, you can get a medium effusion or a small effusion.
Yeah.
Anything ranging from 1 mil up to several mils, I think. And of course, it's space-occupying fluid, so it gives quite a bit of pressure inside the joint and can be very uncomfortable.
We always look out for erosions as well.
Erosions. Not
necessarily here, but they'll basically just look like little defects in the bone where it looks like it's been eaten out.
Like a mouse has been nibbling at the ends.
And then it's always good to put Doppler on that erosion just to make sure that it's not sort of actively eroding away. It's a bit more problematic if there's erosion that's got synovitis within it as well.
So yeah, I think that's most of the ankle covered, the anterior ankle at least. I'll just very quickly show you the neurovascular bundle, but I think we're not far off time there. Let's just see where we are. Should we just show them the angle of the probe placement? So find the medial malleolus, and you want to draw an imaginary line between that and the calcaneus, and that is your probe position. So we're in the transverse plane here. Let's just make sure we've got a bit of bone in the picture.
Got a nice medial deltoid there, deltoid ligament.
We've got your, remembering your mnemonic, Tom, Dick, and Ray, Naughty, Harry. So you've got your tibialis posterior.
Yeah.
Yeah, so you've got your tib post, your flexor hallucis. Then you've got your neurovascular bundle, which everybody knows about but doesn't always get to see. And as you can see here on the ultrasound scan, it looks fantastic.
So it'll be digitorum here, and then hallucis will be down here.
Yeah, should we show them some flow there in the artery? You can see the movement pulsing away.
You can.
Let's show you some blood flow.
So you see I'm on the normal colour flow here, and I'm just going to switch it to the power and see if that makes a difference. So I've got a bit more, so it's a bit more sensitive.
We'll go over this in another program. I just wanted to show you briefly because everybody hears about that, but it's great to be able to see it. Very nice. Let's just have a look at Adrian's little injured ATFL then.
Oh yeah.
Brilliant.
Okay. We will cover the ankle, the actual ankle again in more detail, but I just want to show you the.
Yeah.
The
Well, we've got a program up until including the 6th of August at the moment, so we'll put the ankle in again for the 13th of August.
so can you see this?
Where are you? Oh, you changed there.
I'm wrong way around. Sorry, my fault.
Yeah.
Okay.
So this actually might be the inferior vesicle, and then just slightly higher than that, Abid, maybe is the. Just go up a little bit. No, okay, sorry, my fault. It's just here.
So this is where we think Adrian's had a little avulsion of his ATFL. So can you see this? The bone is suddenly not congruent. It's got this little extra bit sitting on the top, and that's where Adrian's ATFL should be attaching, but we were struggling to make it out properly earlier. We can see another, what's that? Is it a nerve or a little vein artery in there? Well, we can put the box on it and see if we've got any blood flow.
Let's find out where this. There you go.
So it looks like it's probably a vein and a nerve.
Yeah.
And see how close it is to that tip of his fibula where we'd find the ATFL. Just find some fibers off.
Yeah, I mean, they do look like this when you have an injury. They look a mess. It's quite difficult to make them out.
Can you see I'm just inverting his calc? I'm just trying to do a little stress test there, but I don't think you've...
There's two fascicles to the ATFL. There's a superior and inferior. But when you've had an injury, you tend to only just see it as one big lump of ligament.
So yeah, that's abnormal. That's not, it shouldn't look like that. It should be a nice straight line. That's how you move it. Inversion, slight inversion to test it. And that's that. While we're there, we could do the CFL if we like. So just get the you need loads of jelly because you've got the contour of the lateral malleolus and it sort of drops off there. So to get your CFL, you need plenty of jelly in the middle of that malleoli and the calcaneus. We want to put our probe pretty much on we want to see the tip of the fibula.
Yeah, so this is a bit of it here. Let me just do as it looks. So that's it going up here, and it sits like a hammock under these. These are the peroneals.
So I'll just show them the peroneal tendons.
Yeah.
In cross section.
So there's the peroneals, and this is the CFL here.
Yeah. Peroneus brevis and longus there, sitting side by side. Almost looks like a that yin yang sign.
Yeah. And that's the CFL coming under here.
So if you watch me try to hold the probe in place with one hand and try to stress his calc, you can just make out some of that movement. Sorry.
Probably not as young as it is. Fused together.
Yeah, but yeah, interesting. That's a whole other kettle of fish doing the peroneals and lateral ankle ligaments, and to get them in good detail takes quite a bit of time and practice and skill.
Yeah.
So we'll spend a good hour on that next time because that's very interesting stuff. And a little hammock underneath of the CFL and the peroneal complex. So interesting stuff.
Just got a question come in about the Doppler. Please, when you use the power Doppler, how do you know how much pressure and gain to apply?
Well, the least amount of pressure, the better, because obviously if you apply pressure, you will squish whatever you're hoping to show as flow. So the least amount of pressure, the better. In terms of the gain, you want to optimize that. So turn the gain right up, okay, until it's almost flash artifact in your image, and then turn the gain down until it just goes and you just see the like a vessel pulsating, and that's your optimal gain. And you really have to do that for each area that you interrogate. Adjust it, take the gain right up till it flashes, and then bring it down slowly until it just goes, and that's your optimum. Don't forget to change your PRF as well, which is your frequency range of that, obviously to pick up sort of fast flow and slow flow. So Dopplers are, you need to real hands-on to understand that really, rather than just looking at, talking over a lecture. You need to get hands-on with that and see how it changes when you change the frequency and things like that.